Hey everyone, Tom here with MoveEd. Welcome to this presentation on the assessment of acute and subacute shoulder injuries. A quick disclaimer, this is not medical advice and the content of this presentation is of a general nature. Again, it is targeted towards junior or early career clinicians working in the private musculoskeletal setting. Okay, so before we move on, I just wanted to talk about having an approach to formulating differential diagnoses in the shoulder, but this is an approach that you can use elsewhere as well. And just touching on some of the diagnostic pearls and pitfalls that are out there. So in terms of various approaches to diagnosing shoulder problems, one that I like to go with is a pathoanatomic approach. So thinking about the structures that are in the vicinity of the patient's symptoms, and then considering what could go wrong with those particular structures. So thinking about the rotator cuff tendons, for example, problems that could arise with those structures include tears, both acute and chronic, tendinopathy, and then associated tendinopathic pathologies like calcific tendinosis. And I've put in here impingement as a slightly controversial diagnosis and something we'll talk more about at the course. Another example would be the shoulder joint proper. So osteoarthritis can affect the joint. There could be dysplastic change, fractures, infections, are all possibilities. Even avascular necrosis of the humeral head is another example. You could also think about the problem a lot more simplistically. And we know based on the literature that there is some major pitfalls if you try to get too specific, because there's lots of red herrings when it comes to medical imaging findings, for example. So a functional paradigm might suit you better, where you identify the key issue and then maybe sub-classify or further pin down what is underlying that problem. So the stiffness might be the main issue that someone presents with, but there could be pain that's underlying that and subsequent kinesiophobia or muscular inhibition, which means that they're not able to achieve the range of motion that their shoulder joint would actually offer them. It could be truly stiff, so there could be a degree of structural limitation occurring, and that could be capsular, it could be due to osteoarthritis. And another key subtype from a functional perspective could be instability. And it could be that there's a congenital abnormality causing the instability of the shoulder. There could be a functional component to it, and scapular dyskinesia is one that's discussed in the literature, and it could be associated with trauma as well. All right, now moving on to the evaluation, just some key points to consider. Always take a really thorough history when it comes to shoulder problems. Really try and nail down the onset and the progression of symptoms, because often these people are presenting to you when the problem is subacute or chronic. So it's nice to figure out when the problem started. Was there trauma associated with it? Has it gotten better or worse over time? Really nail down the site of symptoms as well. Is it isolated anterior shoulder pain? Is it radiating up the neck, down the arm? Is there associated symptoms which might give you clues to the underlying diagnosis? Really talk about aggravating and alleviating factors, and that can give you ideas for treatment as well. And then have a close think about the person's past medical history and risk factors for some of the more significant pathologies. So malignancy is a good example, but other pathologies that you may not encounter that commonly but that are clinically important might be avascular necrosis, and that's what's shown in the X-ray here. And long-term steroid use or high alcohol intake could be associated with the development of avascular necrosis of the humeral head. Moving on to the examination, the key things here, and things that I think are often missed in junior clinicians, would be to really closely consider the neck as a differential and clear the neck as part of your physical exam. Also with observation, have a good look at the person's shoulder. Is there wasting that you can identify? Is there asymmetry from one side to the other? Don't just go through the motions, actually really closely look and see if you can get some clues. Active range of motion, you want to delve into what's the cause of the deficiency if you identify one. And then special tests, it's worth thinking about what you're actually doing them for. Are you doing a particular test because it's really sensitive or specific? And there's some examples here. Very few shoulder tests are both though. We'll go through that more throughout the course. Thanks everyone.